Yes, sir. Kindly do the slideshow.
Just give me a second. I think it's coming. Okay. So,
Done, sir.
are my slides visible? Uh, am I
Yes,
audible?
yes. Very
Okay.
much.
Okay.
Yes, sir.
Okay. Good evening, friends, and thank you, Robin, for the wonderful introduction. At the outset, I must congratulate all my co-investigators, and I'm grateful to Torrent, the entire team of Torrent, and especially Robin and Kashif Mirza for giving me a chance to be a part of this momentous study, and to my good friend Dr. Sanjay Kalra, under whose dynamic leadership this study was conducted. And I'll be talking about this study is known as the Victory Study. This is a prospective multi-center observational study of Voglibose in type 2 diabetes patients. Now, we all know that today we are the epicenter of diabetic population, and it is projected to increase to around 123 million cases by 2040. At the moment, we have crossed 75 million. In addition to achieving target A1C of less than 7%, unfortunately, hardly 20 to 25% of our patients achieve a target of less than 7%. It is very important to arrest the development and progression of the microvascular complications. And this can only be done if we are able to achieve a target of 7% or less than 7%, depending upon the patient that is sitting in front of us. Now, we all know in the natural history of type 2 diabetes, the first thing to be raised is the first phase of insulin secretion, and that is why we see an initial rise in the postprandial blood glucose. Ultimately, there is a rise in the fasting blood glucose later on, leading to a rise in both the fasting and postprandial. We often tend to forget this fact that the postprandial hyperglycemia is the first sign in type 2 diabetes. Hence, it is very important to not only look at fasting but also postprandial if we want to achieve our glycemic control. And the postprandial is often more difficult to achieve, especially in a country like ours, where almost more than 90% of the Indians have a carbohydrate intake of around 70 to 75%. Ideally, it should not be more than 50 to 55%, but we have a very high carbohydrate intake. And in this era of patient-centric medicine, we cannot ask the patient to drastically stop eating rice or chapatis or wheat and cut their carbohydrate. We can ask them to cut their carbohydrate to certain extent, but then we have to tailor our treatment accordingly so that we can reach our glycemic goals. And one of the best drugs that we have in our armamentarium, yes, anybody? One of the best drugs that we have in our armamentarium is the alpha glucosidase inhibitors. Initially, we had acarbose, but there were a lot of side effects with acarbose, and it was not well tolerated. When Voglibose came into the market, it picked up like anything because it's a simple reason that patients liked this drug because they did not have any side effects of flatulence, and we liked it because it could control the postprandial hyperglycemia. So when used alone as a monotherapy or in combination with other anti-diabetic drugs, it primarily reduces postprandial blood glucose, and its efficacy, safety has been well established in multiple randomized control trials. And they have concluded that it is an effective oral anti-diabetic drug with a good tolerability profile and even cardiovascular benefits. Now, what was the purpose of doing this victory? As I said, this is a real world study. What happens in randomized controlled trials is that we tend to select the patients on a very strictly controlled manner, and there is a strict eligibility criteria for patient inclusion as compared to what happens in our routine clinical practice where we see all types of patients. Now, the real world studies demonstrate the picture of a large data set from a diverse set of populations, and they have a broader generalizability and are effective tool to confirm the result of randomized controlled trials in clinical practice. May I request everyone to please mute themselves? We can ask questions later. Now, there are scarce data available to demonstrate the effectiveness of Voglibose in real-world settings, especially in the Indian population. Currently available literature covers a few Indian studies of Voglibose in real-life settings, but they included a very small number of patients from one or two centers. Hence, Victory, a non-interventional, multi-center, prospective observational study was planned with an objective to understand the usage and effect of Voglibose as monotherapy or as add-on treatment in Indian type 2 diabetes patients. It was a 12-week prospective observational multi-center study conducted between October 2016 and August 2018. The adults were with inadequately controlled type 2 diabetes, A1C of 7 to 10% on diet, exercise, and/or antidiabetic agents were treated with Voglibose monotherapy or as an add-on therapy. And 39 sites in the country participated in this study. And therefore, it includes an analysis of a large population with different geographical regions in India, as I just showed you, right from the north to the south and from the west to the east. The data of participants receiving Voglibose, either zero point 0.2 or zero point 0.3, either alone or as an add-on to the other anti-diabetic agents, based on the investigator's discretion in routine clinical practice, this data was collected. And if you see the number of centers across the country where this was conducted, fortunately, and Jamshedpur was one of the centers, and the first patient was recruited in November 2016 when it was launched from Jamshedpur. Then we had another center in Ranchi, and I think we had two centers in Bihar. Now, the first criteria was that a written consent, informed consent, was taken from the patient as per the ethical regulations. The patients had to be over the 18 years, whether male or female, and they were inadequately controlled. A1C was between 7 to 10% despite the diet, exercise, and other anti-diabetic agents. The Voglibose was used either as a monotherapy in new onset diabetes or as an add-on therapy in patients who were already on treatment. And these patients also gave written consent that we could use their personal and health data prior to the entry into the study. Patients with type 1 diabetes, any medical condition of the patient which would have interfered with the study, history of recurrent hypoglycemia or loss of consciousness, history of ketoacidosis or hyperosmotic state, pregnancy, lactation, women of childbearing potential not ready to use an effective contraceptive method during the study, and patients participating in other clinical trials were excluded from this study. The primary endpoint was a mean change in A1C level from baseline to week 12. There was secondary endpoint of a change in the fasting, postprandial glucose, and body weight from baseline to week 12. The usage patterns, like whether it was a monotherapy or an add-on therapy, was also collected. and adverse events reported during the study period were also documented. The adverse effects were classified as mild, no interference with usual activity, moderate, significant interference with usual activities, and severe, prevents usual activities. The baseline characteristics of the patients who were involved, the mean age was around 54 years, weight was around 71 kg, and they had an A1C around 8.27 with a fasting of 146 and a postprandial of around 232. At the first visit, total patients enrolled were 1542. Around 158 patients were lost to follow-up. 10 patients discontinued Voglibose, and in 9 patients, the A1C values were missing. So the completed visits were for 1,365 patients, whose data was then analyzed. Now, if you see the changes in the A1C levels with monotherapy and add-on, we find that from 8.27% A1C at the beginning of the study, the A1C dropped to 7.29 after 12 weeks, and this was highly significant. Now, there was no difference between the 0.2 and 0.3 milligram of Voglibose as far as the reduction in A1C was concerned. Now, if you look at the fasting blood glucose, again there was a significant reduction from 146 to 119, which was statistically significant. But again, if you look at the postprandial, the fasting here, the 0.3 milligram showed a superior result as compared to the 0.2. But as an add-on therapy, there was no difference between 0.2 and 0.3 milligram. The postprandial had again a very significant reduction from 232 to 180 in the overall group, and the difference between 0.2 and 0.3, if we see the 0.3 reduction was much more from 246 to 178, but there was no differences when it was used as an add-on therapy. As far as the body weight is concerned, there was no significant change in the body weight when it was used as a monotherapy. But when used as an add-on therapy, there did appear a significant reduction in the body weight, possibly because of the multiple drugs. Some of the drugs must be causing body weight reduction. Adverse events, if you look at flatulence, hardly 0.5%, abdominal discomfort 0.3%, gastritis 0.1%, diarrhea 0.1%, leg pain 0.1%. And if you look at these adverse effects, I think they are even less as compared to a placebo. If you look at the usage pattern, 25% of the participants received Voglibose as a monotherapy. 74 or 75% received it as an add-on therapy to the other antibiotic drugs, out of which 12.4% it was a part of dual drug therapy, 36% as triple drug, 19.3% as quadruple drug, 4.4% as 5-drug therapy, and 2% as other combinations. What I would like to point out here is, if you look at the number of patients who were on quadruple and 5-drug therapy, is almost 25% of the patients. That means our patients are not willing to take insulin, and we can still control them with drugs. So even if you can get to the A1C targets with 4 or 5 drugs and their patient is comfortable, I do not think there is any need to start or initiate insulin at this stage, unless of course the blood sugar goes higher. Now, 29% of the patients received Voglibose as an add-on with metformin and sulfonylureas. And we all know that sulfonylureas and metformin forms a biggest chunk of the prescriptions that we use in our country. Now, around 13% were with triple drug therapy, where DPP-4 was the third drug. 7.5% were used only with metformin, and they were mostly patients with new onset diabetes, and around 5% with metformin and DPP4, and 3.4% only with sulfonylurea. That means these patients were not taking metformin because they could not tolerate, or it was contraindicated because of renal dysfunction. And 17% participants received Voglibose as a part of other anti-diabetic combinations with different permutations and combinations. To conclude, the victory study demonstrated the real-life effectiveness of Voglibose monotherapy or as an add-on therapy, which significantly reduced A1C, fasting, and postprandial in patients with type 2. That the contribution of postprandial in the reduction of A1C was tremendous. But one must not forget that even a reduction in fasting in the plasma glucose also contributed in reduction of A1C. And it was the commonly it was added to metformin and sulfonylureas in dual drug therapy, and it was very well tolerated without significant weight changes as a monotherapy. So the effectiveness of Voglibose in a large population with type 2 diabetes seen in the study in the real world reflection of the results obtained in randomized trials. So the results seen in the randomized controlled trials have been replicated in this real world study. Overall, the strength of this study is the large sample size, 1,350 from 39 real-life setups, routine clinics, where patients were seen on a day-to-day, the garden variety, across the varied regions of our vast country, right from the north to the south and the west to the east. This clearly supports the widespread use of Voglibose in patients with type 2 diabetes in real world practice. And I'm sure most of you who are listening to me are using it, but I am just documenting it and giving you the data and stamping that what you are doing is 100% correct. Additionally, it also indicates the enthusiasm and interest of both the patients and healthcare professionals to be part of research undertakings. So if we have more companies like Torrent coming to help us out, I'm sure we'll be able to document and we'll be able to stamp a lot of things that we Indians are doing, but there is no evidence to prove that what we are doing is correct. All of us have been treating diabetes for the last 20, 30, 40 years. And we know the results have shown us that the endpoints have told us that what you are doing is correct. But here is now data in at least one field to prove that use of Voglibose that we have been using since so many years was actually justified. That is the most important thing. And this study was published in US Endocrine in March this year, and I'm proud to be one of the investigation in this international journal. Thank you, my friends, for your attention. Now we'll have an open discussion, and let us ask any questions. I'm prepared, or any comments from your side. I'll be most welcome to participate with you. Anybody who wants to ask a question can please unmute himself and ask the question. Yes, Dr. Dilip Kumar.
Dr. Birmani.
Yes, Dr. Umesh. No, who's that?
Dr. Birmani, it was a nice presentation, really.
Okay, Umesh.
Since very long time.
Sorry?
And to start with few patients, of course, gives some abdominal distension or gas formation. Otherwise, tolerance is very good. Tolerance is very good, and effect is also good. So this is the one of the drug that we are using left and right in our clinical practice. Of course, lower group, lower economical group, and lower middle class group. So I think it's a very good drug. Really, you are very correctly give a very good information.
Umesh,
Thank you, sir.
I remember when we started A-Carbos, we used to tell our patients, you have this tablet after the first bite of your food, so that it doesn't cause all that problem. And that's very inconvenient for the patient. Sometimes they forgot. But here, if you're telling you take it after your lunch and dinner,
Yes,
nothing happens. Patient is absolutely comfortable.
Right, very right. Thank you, sir.
Dr. Dilip Kumar, any comment from your side, sir? Please unmute yourself.
Sir, please unmute your mic.
Okay, Dr.
Thank,
Dilip Kumar.
thank you, Vimani, for a wonderful talk. I'm using this drug in combination most of the time along with the metformin. But even after getting this result, not proper, even after two drug combination, I used to give along with the other drug, that is the sulfonylurea. I do not find any problem with the patient apart from few that somebody say that gas sir banta hai, thoda pet fulta. Otherwise, I've got a tremendous result with the both fasting and postprandial blood sugar level down, and the patient is very comfortable. Sometimes I feel that when you have a patient who are coming that I am not taking insulin, I will not like to take insulin, sir. At that time, we are perplexed how to stop insulin. In some of my experience, I say that yes, I am trying, and I try to give this drug in combination with the Voglibose, with metformin and sulfonylurea. Wonderfully, the patient is tolerating, and the insulin is being replaced with this very drug. It is my experience. So it is a wonderful drug, please.
Thank you, Dr. Dilip. Everybody is using it. Dr. Singhal, would you like to comment? You are a gastroenterologist. Do you see these side effects?
Hello.
Good
evening.
First of all, congratulations. Wonderful talk, Dr. Vimani.
Yeah, unmute yourself.
And congratulations for your publication also.
Thank you.
And yes, I myself is using this drug actually in combination therapy, and I have got very good results for this.
What are your comments
So,
about the GI?
it has got very good tolerance.
Good.
No, nothing. I don't find any GI effect. Some of my patients are using, and they also don't complain of any. In fact, metformin has got a lot of GI problems, but Voglibose as such has nothing. It is well tolerated.
Thank you. I see Anshu Bhattacharya is also there. Anshu, are you there? Please unmute yourself. Any other question?
Hello, good evening. Hello,
Yes.
good evening.
Yes, Anshu. Any questions? How are you?
How are you? How are you too? We are well. Sir,
And take up your mask. Don't worry. It won't spread to the level.
sir, a combination of drugs available and approved by the DGCI with the two drugs. One is no meal, no
Not
pill.
audible, not audible. Please keep your mask away.
Take out your mask and speak. No problem.
No, there is a combination of drugs.
Are you seeing a patient or something?
No, yeah.
Okay. Tell the patient to wait outside.
Hello. Am I audible?
Mask utar do.
Yeah. Now you're audible. Good. Good.
That is no, I want to know what is the rationale behind this combination and how the mode of operation is acting on these two drugs given together.
Which two drugs?
Hello. Hello, Dr. Vimani, I am audible.
Yes.
Okay. Thank you for a nice talk. No, I want just comment what the other speakers are talking. You see, definitely the GI intolerance is a problem, May not be with everybody, but that is a problem definitely with this molecule. Number one. Number two, somebody told I didn't give insulin with this insulin was not required. So I don't agree with this. You see, the HbA1c reduction with this molecule is definitely very, very low. It's not like that. Hardly 0.6 percent maybe. So it can be an adjuvant to insulin, but it cannot just replace insulin. It can never,
It,
never.
it can never replace insulin. I never
Yeah,
said it can replace insulin. See, I am
yeah,
saying if the patient is on 3 or 4 drugs, and if you can
yeah,
get him to target with by adding Voglibose, there is no need to initiate insulin at that time. But if the patient is not at goal, there is no sense in going on adding more drugs and drugs. Then the insulin should be initiated immediately.
yeah, yeah.
That I
So,
agree with you. Dr. Panigrahi, I 100% agree with you. We should
yeah,
not delay initiation of insulin. But
right,
if the
right.
patient is comfortable, if the patient has achieved his targets, there is no harm in continuing with drugs.
At least insulin as soon as possible, as early as possible.
Agreed, agreed, agreed.
Many literature we have all daily we are reviewing this how early insulin utilization is better for in some rare cases maybe you can go on adding OADs, but adding OADs and OADs I don't think it's not a very wise decision. But anyway, but every patient doesn't behave like this. There are many other factors also, patient acceptance, patient adherence. There are also factors. Yes,
Every
that varies
patient,
from.
every patient has an individual
Yeah,
case. You have to decide.
right, right.
You have to decide as per
Yeah, yeah,
the patient. And this is
yeah.
just
100%, 100%, 100%. I agree with you.
there
But
may
very
be
nice talk.
times,
Thank you.
there may be times when you have to start insulin right after metformin, right at the onset. If the A1C is more than
Yeah, yeah,
10.5, 11, patient is symptomatic, then you cannot wait for drugs to act. You have to start insulin
yeah.
immediately.
Right, right, right. Very, very, very correct.
Hello.
I'm surprised. I showed you that there is a significant reduction in fasting plasma glucose. Nobody asked me how does it reduce fasting plasma glucose. I'm really surprised.
I just, I think I missed the first part.
Okay. Can anybody
I
comment
missed the
on
first
that?
part.
Can anybody comment how does it reduce fasting plasma glucose? It is supposed to be specifically a postprandial glucose lowering agent.
Right, right,
Then how does it
right.
reduce fasting plasma glucose? But
Maybe,
we saw the results.
may, maybe fasting. You see, maybe the suppose you give in the night, okay, postprandial, and reducing. You see what happens? Reducing the postprandial, okay, that also that effect continues to the fasting one. That not that directly it reduces the fasting. In many cases, suppose you control the breakfast, post breakfast, that also reduces the insulin dose of the lunch. Like that, if you control the postprandial in the night at night, that definitely helps in reducing the post fasting also. So it is just an indirect effect, may not be the direct effect. That is what my, if you can
Excellent,
explain
excellent,
in.
Dr. Panigrahi. 100 marks to you, 100% marks to you. You are absolutely correct. And this is known as
Okay.
the domino effect or the ripple effect.
Yeah.
If you bring down
Yeah. Yeah.
the postprandial blood sugar in the night, automatically the fasting will come down in the morning. So this is known as the
Yeah.
domino ripple effect. Excellent.
Yeah. Yeah.
Very, very good, Dr. Panigrahi.
Hello. Birmani sir.
Yes.
Good evening.
Good evening.
Sir, my question you have mentioned in your presentation when Voglibose is used alone, it reduces PP more than in combination. Can you explain why?
No, no, no. See, it was when we are using as a monotherapy, the
Yeah.
0.3 milligram reduces more than the 0.2 milligram. But when you are using as an add-on drug, it doesn't matter whether you use 0.2 or 0.3, because there is a reason for this. And when you use 0.2 milligram, it has got a certain effect. When you use 0.3 milligram, now I'm talking only as monotherapy, it has got a superior effect. So it brings down the blood sugar. But when the patient is already on 2 to 3 drugs, the blood sugar has come down to a certain level. And when we add Voglibose, whether it is 0.2 or 0.3, it does not make any difference, because you cannot reduce the blood sugar to a larger extent as you can reduce it if the blood sugar was higher level. So higher the baseline A1C, the greater the fall with any one drug. But if the patient is already on 2 to 3 drugs, adding the fourth drug, here we are adding Voglibose to 2 or 3 drugs, the reduction in the A1C is going to be very, very small.
Okay, sir.
But as monotherapy, 0.3 is superior to 0.2. I hope I'm clear, Dr. Biswal. I don't.
Nirmani sir, one more point which was also discussed
Yes.
was that cases of flatulence which was believed to be there with this molecule, but in this study it showed that it was not very significant and the incidences were very lower. So would you like to touch upon that point also and share the information, sir?
That is because basically it was well tolerated. Simply because well tolerated. That's all.
Right, sir. Are there any experiences anybody would like to
If you
share?
would like to share his experience with this drug,
Okay, thank you, Dr. Bhimani.
thank
Very
you.
nice talk. We'll meet again. Okay.